Thank you very much for inviting me today to talk about my audit I've done. And I'd just like to say thank you to the conference organizers, and I've really enjoyed today and yesterday so far listening to everyone speak. So my presentation is about the management of peritonsillar abscesses, and I'm a senior house officer, FY2 as we call it in the UK, in a small hospital in England. I've taken an audit looking at the management of peritonsillar abscesses, or quinzies as they're also called. Okay, so why did I choose this topic? Well, just to give you guys a brief background, and I'm sure many of you guys already know this because you're more experienced than me, but peritonsillar abscesses or quinzies is a complication of acute tonsillitis where there's a collection of pus between the fibrous capsule of the tonsil and the superior constrictor muscle of the pharynx. Now, it is one of the most common emergency presentations to ENT acute services worldwide. Within the UK, they normally have about 8,000 cases a year, so an incidence of 8,000 a year. However, there is discrepancy in the literature when it comes to treating this condition, with differences in the initial management. Namely, some people decide to go through the aspiration route and some people decide to go through the IND or incision and drainage route, in the type and route of antibiotic treatment used, as well as in the setting, whether inpatient or outpatient. So internationally, from my reading, it is more common for patients to be managed in an outpatient setting where drainage is achieved in the emergency department prior to discharge with oral medications. However, in the UK, even though outpatient management has been demonstrated to be effective, anecdotally, inpatient management remains the default strategy in many centres, including my hospital. There also, like I said, appears to be no agreement on the optimal or prevalent treatment for these quinzies, which the lack of national guidelines probably contribute to. Thus, I actually wanted to do an audit to determine what are the current prevalent practices that our hospitals are doing to manage these quinzies and to help clarify variations in management. And then I was going to compare these to national audits, which looked at managing quinzies to see if our management of quinzies in our hospital is effective. So the objectives of my study, sorry, just bear with me, I'm having some technical difficulty on my side there. So the objectives that I want to look at in this audit are named. As mentioned before, it's to determine the current practices in the management of quinzies in my department in Sandwell Hospital. It's then to compare the effectiveness of these interventions with existing national benchmarks, which came from national audits that were published. And then if our management isn't comparable to these existing standards, I wanted to make recommendations to our department on how the management can be improved, which I would then re-audit. So how did I actually go out carrying this audit? When I contacted people in the trust that were more smarter than me, that were able to give me a hospital number for all the patients admitted into a hospital with a diagnosis code for peritonsillar abscesses or quinzies for a 6-month period, ranging from 1st July to 31st December. Because anyone in our hospital admitted, it's all done online now. So they have a code which tells you the diagnosis, so then I can look up all of these people that were admitted from ED with quinzies. I then want to analyze the data for a range of outcomes, which I will talk in my next slide. These outcomes are mainly used to set benchmark standards, and the same outcomes and national audits or national guidelines looked at. I normally use outcomes from 2 national audits. So there's one done quite a while back, which asked 200 consultants about their practice of managing peritonsillar abscesses. And there's a more recent national prospective cohort study done, which kind of measured peritonsillar abscesses and outcomes. It was a multi-center audit of quinzy studies. Data was collected prospectively on suspected peritonsillar cases over a 2-month period at 42 participating secondary care centers, which covered a population of 16 million. The outcomes that these audits used between them and what I used was on the slides now. So length of stay, so how long each inpatient stayed for, the time from admission to give them antibiotics for the quinzy treatment, the time from admission to give them steroids, the time from admission to actually drain the abscess if it was drained, and also the initial and subsequent management. So what was the initial management for these quinzies and what was the subsequent management? So here is my data. So first, I thought I was going to talk to you about the length of stay. So I had 41 patients in my study of 6 months. As you can see, the vast majority of patients stayed for less than 2 days. 26 out of 41 patients, which is about less than 2/3 of patients, stayed for less than 72 hours. So 1 day's length stay would be 0 to 24 hours, 2 days length stay would be 24 to 48 hours, etc. Now, if I was going to break down this kind of 1 day length stay even more, I broke it down into hours. So specifically looking at the hours of length stayed as a percentage, the vast majority stayed for more than 24 hours, with only about a quarter of patients staying for less than being admitted for less than 24 hours. Unfortunately, no patients were admitted for less than 4 hours, which kind of makes sense, as I think all but 2 patients were, all but 2 patients were inpatients, and thus this could be an argument for more outpatient treatment of quinsys in our hospital. Now, if we move on to how this data that I showed you before compares to national audits, so now I'm just going to look at the days. So it will be, you're looking at this graph on the left. So this is my data. This is the national audit. Now, you have to bear in mind the national audit, this one specifically didn't have any outpatients as well. So this was only of the inpatients. They don't actually take data for outpatient quinsy managements, which actually means that our data is probably more comparable because I only had 2 patients of mine, which were outpatients. As you can see, I feel like the graphs are quite similar, with the admission length being 2 for most patients. In addition, the kind of trend is more where much more quinsys are kind of managed from day 0 within 72 hours, and that's similar to the national audit. However, I'm pleased to say in our hospital, it seems like more patients were managed just for 24 hours, whereas in the national arena, more patients actually after the second day, the next most popular day, days that the patient stayed were 3 days. So I'm actually pleased to say that we kind of showed a shorter stay. Now, if I break down the hours, now I can appreciate that the graphs might be a bit hard to read, so I'll read it out for you what the key means. I'm going to compare the length of stay in hours for my hospital patients and the patients in the national audit. So blue in the pie chart is less than 4 hours, which there's 0% of patients for in my data. Purple is less than 12 hours, green is less than 24 hours, and orange is more than 24 hours. Like I said, our audit results are similar to the national audit. However, the majority of our audit have patients over 24 hours, which is why there's a huge orange circle in my pie chart on the left. Whilst in the national audit, the majority of patients had less than 24 hours, which is the green circle. So overall, my department still has some work to do to discharge patients in less than 24 hours. Now let's move away from admission length and let's go to other things. So time from admission to give antibiotics. This slide shows how quick when patients are admitted to our trust they received antibiotics. I am pleased to say the majority of patients did receive antibiotics within 4 hours. However, as per sepsis guidelines, at least in the UK, antibiotics should be given in 1 hour, which only 9 out of 41 patients had done. Thus, we set 1 hour as a standard, and my department again has some work to do to implement this and make sure all antibiotics are given within 1 hour. If I look at the route of the antibiotic, or the chosen route decided to be given to these patients, all patients in my trust received IV antibiotics. This was comparable to the national data, who had 96% of patients receiving the IV route of antibiotics. Only nationally, 1% had oral and 3% had IM, which was due to probably difficulty giving the drugs, such as cannula issues. As literature has shown, the IV is the best route of antibiotics to treat peritonsillar abscesses. So the route that my hospital is deciding to give the antibiotics is correct as per guidelines. Now, if I look at the time from admission to give steroids, similarly, the data between being admitted and giving steroids shows most patients were given steroids within 4 hours, just like antibiotics. Now, this is probably due to doctors prescribing antibiotics and steroids at the same time and nurses giving them at the same time. So like antibiotics, things can still be done to make sure patients receive steroids quicker and hopefully within 1 hour, which again, we would like to be as a department. This is one of my favorite actual outcomes. I think it's my most favorite outcome in the whole study that I've done. Time from admission to drain abscesses. These tables show the time taken to drain the quinsy from admission. Unfortunately, my trust is slower in draining quinsies compared to national data. As you can see, the majority of quinsies in my trust took longer than 4 hours to drain, whilst in the national audit, most were drained in less than 4 hours. So nationally, about 2/3, 66% were drained in less than 4 hours, while in my hospital, only 40% of them were drained in less than 4 hours. Obviously, like all the other results, I'll explain why in the discussion, which will come later on. This is a pie chart representing the tables on the previous slide. And again, like I said, nearly 2/3 of the suspected peritonsillar abscess patients underwent attempted drainage within 4 hours, which was 214 out of the 325 patients involved nationally, whilst it was only 41% of patients in our trust. As I said earlier in my presentation, at least in the UK, there is no national set management pathway on how to treat peritonsillar abscesses. The results of my audit are on the left, with the initial management being the blue bar chart and the purple bar chart being subsequent management, if any. All patients either had just antibiotics or aspiration, with the majority having the aspiration as initial management in my trust. The most common subsequent management was antibiotics in my study. Now, this is similar to the national audit, which is in the black and white, where most patients had the initial management of aspiration. However, quite a lot of patients had incision and drainage as the initial or subsequent management nationally, whilst in my trust locally, that was not the case. I think the reason why, which I'll come to later, is because just for the staff's practice, there's just not common practice in my trust to have IND done really, and they would just prefer to aspirate and drain quinsies. Okay, so now I'm going to explain why the results showed why they did in my trust compared to the national data. If we tackle each outcome at a time, the admission length was similar, with both data sets having mostly 2 days of admissions. However, the data sets, if you remember earlier, were dissimilar in hours, as only 4 patients in our study were, however, the data sets were dissimilar in hours, with none of our patients being discharged within 4 hours, whilst nationally there are some patients that are discharged within 4 hours. Now, the reason why is that the majority of our patients were inpatients, and thus most would be admitted for more than 24 hours, which again can be an argument for why outpatient management should be done when treating quinsies. The reason why antibiotics or steroids weren't given quicker, we found, was for a range of reasons, such as a medication not being available on the ward, thus having to order it from pharmacy, doctors not prescribing the medications right away or right after they saw the patients, which is due to logistic reasons or them being busy with other patients, etc. And nurses not giving medications as soon as they've been prescribed, which again could be because they're dealing with other patients, more sicker patients, etc. So those are some of the reasons why we didn't reach the 1 hour target of giving antibiotics or steroids after admission. From also analyzing the data, I found the main reason why peritonsillar abscesses aren't being drained under 4 hours, like the national data did show, is because certain doctors aren't confident or able to independently do this in my trust. So let's say in a night shift, if a patient does come in with a quinsy, they probably will wait in the morning where a senior doctor or consultant is available to drain the quinsy. This can be seen when, and I've actually noticed this anecdotally through my placements in ENT in my hospital, when a senior SHO or registrar is first seeing the patient, when the registrar or senior doctor is the first person to see the patient, they normally would drain the quinsy right away. However, when it's more of a junior doctor or someone who isn't an ENT or surgeon who's seeing the patient, they're less likely to drain straight away, which will cause a delay in drainage or wait for a more senior person to come and see the patient. So to try to tackle some of the differences between the results of my audit and a national audit, I recommended to my ENT department to take on some of these recommendations. We should start teaching sessions for junior doctors about quinsy management and include simulation stations for quinsy drainage. I've been to some of these before. It literally involves having some jelly beans in a kind of plastic white cup and trying to drain it with a needle. Codfish liver oil seeds or tablets. I also plan to meet with the senior nursing team from the about the importance of giving IV antibiotics, steroids early to these patients, so they can distribute it amongst the nursing team and try to give these medications much more quicker. I was also going to use infographics for my hospital to highlight to the staff the correct management for peritonsillar abscess in line with national audit results. And finally, I do think my trust needs to create some sort of outpatient pathway where Quincy's can be managed in ED and drained there, and patients can go home, and patients could go home with antibiotics right after this is done as an outpatient. Thus, I would like to create this. My plan would then be to re-audit these results next year after these things have been done to see if my outcomes would be more in line with national data. But I think the potential here is huge. If I did create an outpatient management pathway in my hospital to drain some of these Quincy's, the amount of not only money and obviously financial savings that the NHS can make in the UK, but also the amount of morbidity and mortality that can be reduced would be tremendous. That's it really. Thank you very much for letting me present my audit results. And yeah, thank you guys.